I'm Rachel Outerson, Clinical Assistant Professor of Anesthesia at Stanford. This lecture will be on local anesthetic systemic toxicity, also called LAST. In this presentation, I will review the phenomenon of local anesthetic systemic toxicity, including its clinical presentation and mechanisms, the steps we can take to prevent LAST, and the steps we must be prepared to take to treat LAST when it occurs. Local anesthetic systemic toxicity is a highly variable constellation of signs and symptoms caused by exposure of cells to toxic levels of local anesthetic. This definition encompasses a broad range of presentations involving the cardiovascular system, the central nervous system, or both. Presentation can be very different in type of symptoms and severity. In some cases, it may manifest as relatively mild neurological symptoms, such as tinnitus or perioral numbness, and it may be self-limiting. Or it may start with mild symptoms and then progress to more severe. In some unfortunate cases, the first symptom noted may be cardiovascular collapse. It may occur immediately upon injection of local anesthetic, as with accidental intravascular injection, or it may be delayed by several minutes, hours, or even days in the case of prolonged local anesthetic infusion that slowly builds to toxic levels. It is a relatively rare phenomenon. A 2018 review found an approximate incidence of LAST after peripheral regional anesthesia of 3 per 10,000 blocks performed. But there is no universal mandatory reporting, and these cases were gleaned from a published literature and self-reporting on the lipidrescue.org website, so this may be a falsely low number. Recent publications of reported cases of LAST cite a mortality rate between 4 and 10%. This slide lists the most common signs and symptoms of LAST, divided into CNS and cardiovascular manifestations. From top to bottom, they increase in severity, and this may also be the order in which a patient progresses through toxicity. First reporting prodromal symptoms of slurred speech and metallic taste, then progressing to confusion and seizure. Or first manifesting tachycardia and hypertension, then progressing to asystole. However, patients do not follow a script, and presentations, as I mentioned before, are quite variable. In reviews of reported cases of LAST, the most common presentation involves only central nervous system features. The next most common presentation of LAST involved a combination of both CNS and cardiovascular features. A less common presentation is that of isolated cardiovascular features. The single most common reported presenting feature of LAST is seizure, which accounted for 53 to 77% of LAST presentations, depending on the paper. Of the cardiac manifestations, tachydysrhythmia is the most commonly reported in published cases of LAST. So why does LAST happen? We usually think of local anesthetic agents as sodium channel blockers. They attach to the intracellular domain of neuronal sodium channels, thereby inhibiting transmembrane ion movement and depolarization. But in the case of toxicity, the mechanism is much messier. Depending on the concentration present, local anesthetics can also block calcium and potassium channels and interfere with a host of intracellular and transmembrane processes, including critical metabolic processes like the production of ATP, oxidative phosphorylation, and carnitine acylcarnitine transferase. With such a variety of potential targets for toxicity, it's no wonder that the presentation of LAST can be so varied. In the case of cardiovascular toxicity, a combination of these mechanisms manifests as not only depressed conduction, as one might expect from blockade of cardiac sodium channels, but also reduced cardiac output and decreased systemic vascular resistance. The first step in preventing LAST is to carefully plan administration of local anesthetic. Plan your dose, taking into account patient weight and characteristics that might make them more prone to toxicity, the vascularity of the site of planned injection, the specific local anesthetic agent, and whether you will use any vasoconstricting additives. Consider making your planned dose of local anesthetic part of the procedural timeout before performing a block. Once performing the block, the use of ultrasound, aspiration to confirm no blood return before injection, injecting slowly and in small increments, can all aid in preventing LAST. Ultrasound should be used not only for watching for vasculature to avoid, but also watching the spread of your local anesthetic. If you don't see it on the screen when you inject, you need to stop and find it before you continue. Let's discuss patient factors that might increase risk for LAST. There are many factors to consider. Females are at greater risk than males. Low muscle mass is a particularly significant risk factor, even more than just having a lower weight. The muscle mass itself seems to be significant as muscle binds quite a lot of local anesthetic. Extremes of age are significant. Infants are at particular risk, even when doses considered safe are used. The most recent Pediatric Regional Anesthesia Network data showed a rate of LAST in children under 6 months old that is 6-fold higher than the rate in other children. They fall into the category of both having low muscle mass and low protein binding. Other low protein binding states that we should be aware of include patients with liver disease or malnourishment or during pregnancy. Cardiac diseases of particular concern include arrhythmias, conduction abnormalities, previous ischemia, and congestive heart failure. Metabolic diseases of concern include diabetes, isovaleric acidemia, mitochondrial disease, and carnitine deficiency. Just as important as the specific characteristics of your patient is where you actually put that local anesthetic. Nerve blocks are performed in a variety of anatomic locations with varying vascularity. Plasma concentration of lidocaine after an intercostal block is 3 times higher than it is after skin infiltration. Now this chart shows a very basic representation of what blocks are more vascular versus less vascular. And as you can see, epidural is slightly more vascular than brachial plexus. However, we do notice that seizure is up to 5 times more likely after a peripheral nerve block than after an epidural block. So we can't blame everything on the vascularity. And this may have to do with the total dose of local anesthetic that's used for a peripheral nerve block being significantly higher than that used in an epidural sometimes. So let's talk about safe dosing. This is a chart I compiled from recommendations from the physician's desk reference and from Miller's Anesthesia. You'll notice some are written in ranges where the two sources did not agree. The search for a true safe dose of local anesthetic has always been confounded by the lack of trials to establish the threshold for toxic levels. Such studies will never be conducted on humans. Instead, we have traditionally gathered information regarding toxicity from animal studies and case reports. From these sources, manufacturers publish maximum allowable single doses and daily doses. All of that is to say, these are our best guess. So you may notice that bupivacaine has the lowest safe dose at 2.5 mg per kg, and you may have heard that it is particularly cardiotoxic. And that is true. Compared with other local anesthetics in common clinical use, bupivacaine is more lipophilic and has a greater affinity for voltage-gated sodium channels. Those qualities likely contribute to its cardiotoxicity. Resuscitation after LAST caused by bupivacaine is more difficult. So, is it reasonable to choose a less cardiotoxic local anesthetic? Yes. But can you just avoid bupivacaine and then you don't have to worry about LAST? No. Ropivacaine and lidocaine still account for a significant proportion of LAST events. Even the quickly metabolized ester local anesthetic 2-chlorprocaine has been reported to cause LAST. So one cannot fall into the trap of believing they can't cause toxicity just because they did not administer bupivacaine. Even once you have made every effort to plan a safe regional nerve block, taken into consideration your specific patient, injection site, and local anesthetic, and taken pains to inject safely, toxicity can still happen, so you must be ready for it. As soon as you suspect local anesthetic systemic toxicity, stop injecting. Call for help. You will need extra hands because there are 4 critical aspects of LAST treatment to manage: airway and oxygenation, seizure treatment, intralipid administration, and ACLS. First, administer oxygen and assist ventilation as required. Airway is still number one. For seizure treatment, the preferred first choice is benzodiazepine. Small doses of propofol can also be used, but are not the first choice because larger doses may further depress cardiac function. If seizures persist despite treatment, small doses of succinylcholine or another neuromuscular blocker should be considered to prevent severe acidosis and hypoxemia. Lipid emulsion therapy or intralipid should be given early, as soon as possible. Getting it started quickly is more important than giving it as a bolus versus an infusion or even the specific dose. However, the recommended dose is a bolus of 1.5 milliliters per kilogram over 2 to 3 minutes if the patient is less than 70 kilograms, or just the 100 ml bag for a patient 70 kilograms or over, followed by an infusion of 0.25 milliliters per kilogram per minute, or 200 to 50 mLs over 15 to 20 minutes if the patient is over 70 kilos. If circulatory stability is not attained, consider a rebolus or increasing the infusion. Continue the infusion for at least 10 minutes after circulatory stability is attained. Now, ACLS is critical to survival after cardiac collapse from LAST. However, cardiovascular collapse from LAST is a very different clinical entity from cardiovascular collapse from other causes. There is nothing inherently wrong with the cardiac myocyte suffering from LAST. It just has a toxic substance bound to it, and your primary goal is to perfuse those myocytes in order to deliver the lipid emulsion that will remove that toxic substance. With that in mind, outcomes are better for these patients with certain changes to standard ACLS protocols. Doses of epinephrine should be smaller, on the order of 1 mic per kg. Vasopressin should not be used, and that's because both vasopressin and large doses of epinephrine have been associated with worse outcomes in animal studies. No medications with sodium channel blocking properties, such as lidocaine or procainamide, should be given, as they will only worsen the condition. Beta blocker and calcium channel blockers should be avoided, as they can further depress cardiac contractility. If you wish to give an agent to treat ventricular tachycardia, amiodarone is preferred. Expect that ACLS may need to be prolonged. Think early about the potential need for cardiopulmonary bypass. This diagram illustrates the concurrent nature of the multiple aspects that must be managed during treatment of LAST. Airway, ACLS, and seizure management at the top, and lipid emulsion therapy down below. This diagram also goes on to show post-arrest management. That includes continuing intralipid infusion for at least 10 minutes after cardiovascular stability is achieved, and observing the patient in a monitored setting for a minimum of 12 hours after a LAST event. So let's talk about lipid emulsion therapy, sometimes referred to as intralipids. The idea behind its use is that local anesthetics are lipophilic molecules and will bind to it and be pulled away from the cell where they are having toxic effects. It was originally described as acting as a sort of sponge or lipid sink that would pull local anesthetics away from the cell and hold it. However, recent research suggests that lipid emulsion works more as an active carrier that scavenges local anesthetic away from highly perfused organs like the heart and brain and takes it to organs that store it, like muscle, or metabolize it like the liver. It has also recently been shown that lipid emulsion exerts inotropic and lusotropic effects on the heart in animal studies, suggesting that this may further assist in the reversal of cardiac toxicity. Luckily, the side effects are minimal from a one-time dose. There is a recommended 12 milliliter per kilogram upper limit of dosing. Luckily, it usually takes a much smaller dose than this to reverse toxicity. One important side note here is that while propofol is also a lipid emulsion, it is not an appropriate substitute for lipid emulsion therapy. Lipid emulsion therapy is given as a 20% emulsion, and the initial bolus for a 70 kilogram patient is 100 mLs. Propofol is a 10% lipid emulsion, meaning that the volume required to give an equivalent bolus of lipid would be 200 mLs, which is 2,000 milligrams of propofol, or approximately 10 times the dose used to induce anesthesia in a person of that size. That amount of propofol would undoubtedly contribute to cardiovascular collapse in an already unstable patient. In summary, local anesthetic systemic toxicity is a complex and multifaceted phenomenon. In order to prevent it, one must plan procedures with care, taking into account drug, patient, and procedure characteristics, always keeping in mind that there is no one safe local anesthetic drug. Careful injection practices and use of ultrasound reduce your risk. However, one must be alert and have suspicion for local anesthetic systemic toxicity, whether in the context of your own box or local anesthetic administered by another provider. With early recognition and knowledge of the correct modalities of treatment, patients can make a full recovery. Thank you.